that on November 4th, SHM is holding the first ever meeting to look at the rise of, or to look at the adoption of the hospitalist model of practice by nearly every specialty in medicine. So this is in my view, a really fascinating phenomenon, and I suspect a number of you are at hospitals that have either a surgical hospitalist or a neurology hospitalist or all of those things, a laborist. I think this is changing the nature of hospital medical staffs and raises a lot of really interesting questions that we intend to discuss at this November meeting. So it certainly won't be a clinical meeting about how to take care of sick people. It'll instead be a meeting to talk about how physician practice is organized and what might be its implications. So it'd be appropriate for chief medical officers and so forth, as well as practicing doctors. So now let me turn to talking about hospitalist compensation. And I have a couple objectives here in the next 10 to 15 minutes. One is to provide you with highlights of the latest survey done jointly by SHM and MGMA, survey of hospitalist compensation. Once I give you a few of those numbers, just to make sure we're all on the same page, I'll talk about some of the philosophy and different ways that compensation plans can be structured. So let me start with talking first about the amount of compensation. So this is survey data. Respondents completed surveys very late in 2010, so about 9 or 10 months ago now, and reported these kind of compensation amounts. The numbers distributed over the map here are for the region. The South earns the highest median compensation at $246,000 annually. And this, I should say, this is non-academic practices and only hospitals that care for adults, so not pediatric hospitals. And if you look at the trend in hospitalist compensation, it has been steadily rising. The total amount, dollar amount, has been rising ever since we've been measuring it, starting at about 1998. So it's now up to these amounts you see here. So you might be inclined to think, well, the South is probably the best place to practice then. It's where you make the most money. Well, let's look a little more closely at that. Here is data showing the amount of work that hospitalists do to generate their compensation. So in the South, those doctors work harder. And we've reported workload in both number of billed encounters annually for a single full-time doctor and number of work RVUs generated annually. So those vary by region, just like compensation did. So the South has the highest income, but also the highest workload. So I think the most interesting question to think about next is the juice to squeeze ratio. That is the dollar amount of compensation per unit of work earned by hospitalists. So it turns out that in the South, despite having the highest total incomes, their compensation per unit of work, and in this case per work RVU, is actually lowest at $52. So if you're really out to make the most salary per click, you might want to be in the Midwest instead of the South. I think it's very important anytime you're evaluating a practice and whether compensation is well matched for the work that's being done. It's important to actually do this calculation. It should take all of 2 or 3 minutes in most practices to get the total productivity for the practice and the total salary paid across all doctors, and just do the math, and you'll get a dollar per RVU figure, and you can compare it to these kinds of numbers. Now, let me drill a little deeper, talking about the relationship between compensation and productivity. This is sort of a complicated graph, and I'll walk you through it. The red line that trends up as you move left to right is total compensation, that is total dollars paid to a single FTE hospitalist by quartile. So the red diamond at the bottom left is the first or lowest quartile of total compensation at $188,000 annually. Moving all the way to the right, the top right-hand red diamond is the fourth or top quartile of compensation at $260,000. Now the blue line is something different. The blue line is compensation per work RVU, or what I call juice to squeeze ratio. So those who are the least productive hospitalists, that is in the first quartile or the left-hand side of the graph, they actually earn the most per unit of work or per work RVU. So the least productive doctors have the highest compensation at $73 or almost $74 per work RVU. Those hospitalists who are very highly productive in the top quartile, to the right-hand part of the graph, actually have the lowest compensation per click or per work RVU at $40, almost half of what the less productive doctors make. Now, it's not that anyone has specifically designed things to end up this way. It's a function of a number of factors, and this is actually true in most any specialty that you look at. The very highly productive doctors in any specialty tend to make less per unit of work than the less productive doctors. So it's worth keeping in mind. If you work a lot harder, odds are your income will rise, but it will not rise in perfect proportion to the amount of increase in the work you're doing. So that's all I wanted to say about the amount of compensation, a very quick tour through dollar amounts. Let me now talk about the method of compensation, that is how it is paid to hospitalists. So most practices have something that looks like this, 3 elements that in this case I've shown thrown into a funnel, mixed together to create the overall compensation method. And it's very common that a practice will have a fixed element, so that's typically an amount of money that's paid either every 2 weeks or every year. It's an amount that's known in advance. It doesn't vary. It's fixed. Many practices have a production component. If I remember right, around well over half of hospitalist practices have some salary component tied to production. And then many practices also have another salary component tied to performance, usually things like performance on quality measures. So these can be mixed together in any way that you think is appropriate. In most cases, in most practices, the fixed element winds up being 80, 90, 95% of total annual compensation. And any production and performance elements tend to be pretty small. Now, my bias, though, is that you should think about changing that and instead creating a compensation plan that is weighted much more toward production. And I'll tell you why I think that in just a minute. I also think that it is important to have a very meaningful performance component. Now, should you have a fixed component of compensation? I think that's debatable. Essentially, every practice does, or nearly every hospitalist practice does have a fixed element. And as I just said, in most cases, it's the largest element. But I think that can create some problems. And if you want to get creative, I encourage you to think about changing to a very small or no fixed compensation element and making the production element larger. Now, the reason for that is that fixed compensation tends to be seen as reassuring, and it provides security for the hospitalist. I think it's true. It does do that. So if you sign up to be guaranteed to get paid the median hospitalist compensation, that may sound like a pretty good deal. The problem is when you take that deal as a hospitalist, you are essentially obligating your employer to decide how hard you have to work to justify the compensation that's been promised. So you don't get to take a fixed compensation and then decide for yourself how hard to work. When you take a fixed compensation, somebody else is going to decide that for you. And you're almost never going to be happy with another person's decision about what your workload should be. I don't ever want anybody telling me, John, you don't work hard enough. You need to see more patients, or you're working too hard. I want to be able to decide that for myself within reasonable boundaries. And if I angle for a largely fixed compensation, I lose the ability to decide for myself how hard I work. somebody else will be telling me how hard to work, and I'm probably never going to be happy about that. So I think that's an argument for making the production component of compensation really significant. Now, hospitalists are quick to point out a number of reasons why productivity compensation is potentially a bad idea. And I've listed those on this slide on the left-hand side, a number of concerns that are often raised with paying hospitalists through production compensation. And on the right-hand side, I've given an alternative view. Now, for the sake of time, I'm not going to walk through each one of these, and you can download this slide presentation later and look through this yourself. I will say that productivity compensation is not perfect. There is no perfect method of compensation. Clearly, paying on production has some potential weaknesses, but I think it solves enough problems that it may be that its flaws may be worth living with in many cases. And the practices I've worked with who have moved toward production compensation find that they more often have a mindset of owning their practice. They tend to thrive more, in my view, than those who are paid solely through a fixed compensation. Now I'm about done. Let me just turn to a couple other things. The title of this presentation is Creative Compensation. I think the place you can get most creative is in thinking about a quality incentive. So that 6 or 8 years ago, almost no hospitals had any sort of quality incentive in their compensation plan. Now very many do, more than half. And so just some thoughts if you're thinking about implementing a quality incentive. It's not a simple thing to do. It's simple to conceive of, but the devil is in the details, and operationalizing it in an effective way can be tricky. So I thought of a few things that are good to keep in mind when you do this. One is, if you're going to use a quality incentive, be sure to use metrics you're already measuring. Don't set out to begin measuring for the first time ever a metric that you intend to use as a basis of compensation. For example, your hospital might decide that they value discharge orders being written early in the morning. So you say, all right, for our first run at a quality incentive, let's pay for all the discharge orders written before 10 a.m. Well, you're going to run into problems because it turns out it's hard to measure that in many cases. The data that you get back may not be what you expected, and people may begin to feel like you didn't measure it in the right way. Suddenly your incentive gets a lot of holes in it and can cause problems. So instead, when you start with an incentive program, I would only use things that the hospital has been measuring for quite some time already, and people have developed some comfort with that data. I think you should consider rotating metrics. You don't need to be wedded to the same ones every year. So maybe pneumonia core measure for a couple of years, but then move on to something else. You should compensate on a sliding scale rather than simply an all or none. If you perform at this level, you get all of it, and if you perform 1/10 of a unit below that level, you get none of it. That's a bad idea. Try to make it a scaled payment. For hospitals' quality metrics, it turns out to be tricky or impossible in many cases to pay them on an individual basis. So most lend themselves to paying the entire hospital's group the bonus for performing on a quality metric. Each full-time doctor would get the same amount, for example. And the really tricky part about a performance or a quality incentive is making sure that you've made it appropriately challenging but not impossible to reach. If you make it too easy to reach the quality goal, people will ignore it. It's not changing behavior. You're not really accomplishing anything. If you make it unreasonably difficult, the same thing. People will simply give up and ignore it. So the really tricky part is making sure that you set the thresholds and the targets at a level that causes the hospitalists to stretch and change their behavior and doesn't become something they ignore. And just to let you know, if you choose to download this presentation, I've included a couple references. The first that I've mentioned here is an article I wrote for the hospitals a few years ago that talks about some incentive compensation issues and presents more survey data about what groups are doing. And then the next item on this slide is a plug for our November meeting about hospitals across all specialties. So let me stop there, and let's now open it up for questions and answers and hear from Chris and Randy some also, our other panelists.
Before we have a question and answer session, we do have a poll question to wrap up the session. Please go ahead and respond to the following question by clicking on the appropriate answer on your screen now. The question reads, what area of compensation are you most interested in? The appropriate amount of compensation, how much compensation should be fixed versus variable, creating a portion of compensation connected to productivity, compensation connected to performance on quality measures, or compensation connected to overall citizenship of the doctor. Okay, so the results of the poll are 20% of you said the appropriate amount of compensation, 12% said how much compensation should be fixed versus variable, 20% said creating a portion of compensation connected to productivity, 29% said compensation connected to performance on quality measures, and 19% said compensation connected to overall citizenship of the doctor.
All right, so fellow panelists, it sounds like people are most interested in hearing about creating a portion of compensation connected to quality measures. We can talk about that, although honestly the interest across these various topics or various categories was pretty well spread out. Now, Meredith, you'll now be soliciting questions, I think.
Yes. At this time, if you'd like to submit a question to our panel, you can do so by raising your hand using the icon that is within the toolbox you see on your screen, or you can type the question into the available chat space. If you raise your hand, I will call on you by unmuting you, and you will then be able to ask your question. If you type it, I will read it out loud for you. Don't forget, the presentation will be available online within 1 week of today.
And so, Chris and Randy, you guys have any comments about the stuff I just went through? Any additional perspectives?
I just want to emphasize, when you create an incentive, it has to be attainable, like you said, because if it's not attainable, it actually becomes a disincentive at that point.
And I should have said, Chris and Randy, why don't you guys introduce yourselves and say something of your background and your day job so people will know.
Chris, you can go ahead and start.
So my name's Christopher Smith. I'm Chief Financial Officer for the Western Division of Team Health. I work with emergency medicine and hospital medicine. I've been with Team Health for 10 years. I'm a CPA by trade. And I've worked, I guess one of the most hazardous things I can do as a CFO is mess with people's compensation. So when you do it, you really got to tread lightly.
Yeah, my name is Randy Mitchell. I am the National Director of Hospital Medicine Recruitment for Team Health. I've been in recruiting for, next year will be 30 years. So all that really means is I'm just old. But basically just seen lots of things done in different ways, and I really don't think there's a perfect one way to do it or an imperfect way to do most anything. There's lots of variables and that sort of thing. It's just a matter of creativity. And that's where all the fun gets into place, I guess.
If we're still waiting for questions, Meredith, let me say that to really talk about very creative things, things I haven't mentioned so far, a number of practices have various non-cash compensation things beyond the traditional benefits package. Some have sabbaticals. I think it's a very attractive thing to consider. That would mean a lot to me and keeping me at a place. And it's, of course, can be tricky to figure out how to operationalize that, but a sabbatical could be a great idea. I worked with a practice that seemed to have great success with a deferred compensation system. So every year you made X, and it was a really high number, very, very much above typical survey numbers. But about $20,000 of that wasn't paid to you until 2 years hence. So you had to stay around. You had to still be there to collect it at that point. And that seemed to have worked very well in promoting happiness. The doctors liked it, and it seemed to reduce turnover. And if I remember right, it seemed that it had some tax advantages for the employer. It was, I believe it was taxed differently in some way, although I'm not an authority on that.
Okay, John, we have a couple people with their hands raised, so we'll start with them, and then we'll move over to the questions that have been submitted in the chat. So Brad Sherman, I'm going to go ahead and unmute you. Your line has been unmuted, and you can now ask your question.
Hi, John. This is Brad Sherman in New York. I just had a question about your comment. Do you have any suggestions for quality metrics for nocturnists?
That's a great question. You know, I think many nocturnist programs don't really have a quality metric outside of those that the group participates in as a whole. So by far and away the most common quality metrics used as a basis of compensation are performance on CMS core measures, pneumonia, heart failure, and acute MI. Those are nearly always paid on a group basis, and so typically nocturnists are eligible for the standard share of that sort of payment. Apart from that, I guess I would think about issues related to admission in particular. So while it might be very difficult to implement, you could think about a bonus for good medicine reconciliation. You could, one of the things we have historically had trouble with in our practice is the CPT coding done by the night doctors. They just, it was just hard to get them to pay a lot of attention to it. And so we implemented a salary bonus for proper coding. And we're performing well on a coding audit. And certainly that's applicable to the night doctors too.
Okay, our next question comes from Tiffany Mose. Tiffany, I'm going to go ahead and unmute you. Your line has been unmuted, and you can ask your question.
Hello, my name is Tiffany Mose, and my question is, what is the most appropriate way to propose a change in the existing compensation model?
Yeah, that's a great question. Tiffany, where are you from?
I'm calling from Roanoke Rapids, North Carolina.
Okay, terrific.
And can I address that?
Yeah, please.
You know, I'd probably say three principal things: communication, communication, and communication. I think you need to give a lot of lead time. You need to introduce what you're going to do in terms of, you know, come to them with an idea of what you want to do, not let them define it. You know, you need to lead the way, let them know what the steps are, get them comfortable with it. We often do parallel modeling so they can see what the impact would be, so they can get a level of comfort. So when you do cross over to the new compensation, they already have an idea as a group and oftentimes individually of what's going to happen to them in the future. So you have to build up that trust, that comfort level, make it understandable to them, but just be prepared to take your time.
And
Yeah,
I'd like to
yeah,
I was going to say on the recruitment side of things as well, I totally 100% agree with what Christopher was saying. Education and buy-in from your existing people that you have in place is paramount. If there's any perception, true or just perceived on their side, that something's being forced down their throat, that's going to come through very negatively, and toward any potential recruits, that's going to be thrown out almost without even words being said. I mean, it just comes across. So it's just very, very important to have all that pre-buy-in up front before you ever begin to continue on the recruitment side of things. And like I said, just buy-in, and that's just communication. I agree.
Yeah, I think you need to anticipate that it's likely that doctors will go through the Kubler-Ross stages of grief, and they'll deny and they'll bargain, and that just takes a while to work through all that mentally. So one of the things that we've seen work well is if you're going to change the standard method by which salary is calculated and paid, before you make that change, actually provide spreadsheets. This is what you would have made last year had we been paying you using the new system. This is what your paychecks would have looked like last year. and even run 2 systems concurrently. So we'll continue to use the old system another 6 months. No change to the way your paychecks will be calculated and paid. But every 2 weeks when you get your paycheck, we're also going to give you a report of how that check will look different with the new system. So you can get some kind of comfort level and start to understand how that will work before it actually gets turned on. So that can be a valuable thing. The last thing that comes to my mind around getting ready for a change is if you implement something like a quality incentive where you expect the doctors to change their behavior and perform well, that needs to be accompanied by a plan to improve performance. So if you're going to pay an incentive for raising patient satisfaction scores, you don't just write down how the incentive works. You also create a plan for how you're going to keep patients happier. And the money, the purpose of the incentive and the money is to get people to adhere to the plan and actually implement it enthusiastically. So don't just set out some money and say, do well and you'll get the money. Have the money be accompanied by a plan for how they can do well.
And I guess the last thing I'd like to say is if you're going to do a comp change, try to time it with an increase in compensation because you've got a positive in there overall.
That's right. Yeah, practically speaking, that's been an experience I've seen over and over and over, that changes in comp often are accompanied by an increase in comp to get buy-in. So that's a great point.
All right, our next question comes from Patricia Lewicki. Patricia, your line is unmuted, so you can go ahead and ask your question.
Hi, this is Patricia Lewicki from Connecticut, and we are interested in hearing about compensation plans that include an incentive around patient satisfaction.
Okay.
Do you know of any?
Yes. We do a thing is we actually create a fixed pool, and the pool is distributed as a function of patient satisfaction, how they scored in terms of the hospital's target. What percentage of the hospital did they hit? 50% of the hospital target, 110. You've got to make sure you're able to measure it individually. So whatever tool they're using, you have to be able to get individual scores if you're trying to manipulate that. I think it's kind of hard if you're doing the group as a whole and you get the whole group and you're trying to motivate the group because you can't select out individuals who might be the problem and who might not be. So I think it's most effective if you can measure individual performance, create the pool, and those people who perform better get the lion's share of the pool.
I think that makes sense. My experience has been it's exceedingly difficult to separate out patient satisfaction by doctor, since nearly every patient is seen by at least 2, if not more, hospitalists. So that I agree, that is absolutely the goal. And if you think you can do that effectively and measure individual physician performance on patient satisfaction, you should do that. But many places find they just can't feel confident in the numbers they're getting. Now, I think nearly every hospital, their patient satisfaction vendor can give you data by doctor. The problem is that data is contaminated. So if you look at my data, the patients that I discharged last month and their patient satisfaction scores, there's several of them that I only saw them for the discharge visit. It's really someone else that probably influenced patient satisfaction a lot more than me, and so forth. So it gets tricky to separate it out. Our group decided to create an incentive that is based on the group's performance. And so we all, in theory, are nudging each other to do better. And we decided to compensate based on the 3 physician-related HCAHPS questions. So those are, let's see, I'm doing this from memory. They are, did the physician explain things well? Did the physician listen? And did the physician treat you with courtesy and respect? Of the HCAHPS questions that get reported publicly, those are the 3 physician-related ones. So we used our historical baseline performance as a group and set as a target, improving it by a reasonable amount. And we've had modest success, I would say. It actually turns out to be tricky to move patient satisfaction numbers. One thing to keep in mind is that a huge portion of hospitalist patients are not eligible for the HCAHPS data set. If a patient is discharged to any place other than home, or if they die, of course, they aren't eligible. Well, that's a large portion of our patients. So it turns out that only a pretty small number of our patients get surveyed, so moving the number meaningfully can be pretty tricky.
Okay, our next question.
Still worth doing.
Our next question comes from Brenda Hall. Brenda, you've been unmuted, so you can go ahead and ask your question.
All right, thank you. Hi, Dr. Nelson. This is Brenda in Nashville. How are you?
I'm good.
Good. Just very quick, we have several tiers of compensation based on years of service, 0, 3, 3 to 5, and greater than 5. And I was just curious what your opinion was as far as compensating hospitalists based on their years of experience as a hospitalist.
So, Chris and Randy, does Team Health have a policy around that, or do you have feelings about that?
On the recruitment side of things, and not necessarily speaking for Team Health, but from the experience that I've had over the years, my personal opinion is obviously your director candidates, your facility medical director or whatever, they're going to have extra compensation for all the individual things they're going to be doing up and beyond just seeing the patients, et cetera. But other than that, I'm a fairly strong component that the base salaries should be one and the same for everybody, and then the difference would be in the bonus potential as far as for what they see and do and the encounters they see. They don't all make the same base. I mean, they all get the same base, but their bonuses are going to be different based upon their productivity is what I'm saying. So I would be more encouraging toward that than I say, okay, if I've been a doctor for 3 years, I make this. If I've been one for 5 years, I make this, or whatever. And I think that across the board, I think that from my experience, the physicians like that more so than having some control on what they're actually going to make versus just being a doctor for X number of years in this thing as to what they should make. That's just my opinion. But Christopher, what do you think?
I'm always a big proponent of productivity-based compensation. We do have some arrangements where we reward longevity and recognize that, but is there a real link between longevity and improving performance? So that's, I'm always in the performance category.
Yeah, so I think this is a fascinating issue, and my sense is many people, if not the majority, tend to feel like a tiered system makes sense. A salary ladder is perhaps a good idea. I think it probably does have some benefit in reducing turnover, at least a little bit of benefit. But I actually share Chris and Randy's opinion. I don't know that it's a smart thing. The idea is by staying longer, you're worth more. Well, I don't know. I'd love to take a poll. Well, we can't do this now. Technologically limited. We could create a poll this fast. But I would love to know people's opinion of at what point is a hospitalist most valuable as a clinical care provider to a practice. And my feeling is that someone just out of training, if we add them to our practice, that for the first 6 to 9 months, they are clearly less adept, less efficient, less skilled at moving patients through the system. They're not as good a doctors as the people who've been here longer. But, boy, that washes out pretty quick. Within a year or so, they're just as good as the people who've been here a long time in taking care of patients. And actually, I think I'm really drawing on my own experience. I've been a hospitalist 23 or 24 years. I actually think there's probably a descending limb of that curve, too. And after a while, you sort of, maybe you're a little less flexible, a little ossified, less willing to adapt to things, and maybe a little less valuable to a practice, less energetic, and don't want to see quite as many patients. So I don't think a doctor's value increases steadily with time in service. And so I don't think it makes sense to pay for that. One thing that we have done in the practice I've been part of is for the first 18 months we pay modestly less, and then it steps up to the mature level, and that's the only step. And that's not because the doctor is worth so much more at 18 months. It's merely to recover what it cost us to recruit the doctor, in essence.
Now, was that
but after that, I'm not sure a ladder makes a whole lot of sense.
Was that more of a vesting toward the bonus potential versus their salary, or was it the salary was affected by that for that 18-month period?
Actually, it was. We don't do that anymore. We start our new people at the same rate as the mature people. But
okay,
we didn't have there was no bonus to vest in back then.
Okay.
That first step. So so I think if you're in a big organization like Kaiser and they have a salary ladder, I actually don't know if they do or not. But if they do for all their doctors, well, then they should have it for their hospitalists too. That makes sense. But if you're just a hospitalist practice that's not contractually part of a larger multi-specialty group, then I don't think I would put one in place if you don't have it already. I'm not sure it's terribly harmful, but I just don't know that you're getting much for it. And honestly, the guy who's been there 8 or 10 years is more likely to view the lower salary in the first year or two as simply a withhold. All you're really doing is paying the new guy less than they're worth, and asking them to stay around long enough to allow their pay to increase to what they really are worth. So
okay,
it may impede recruiting.
We have one more person with their hand raised, and then we can take a couple from the questions in the queue. Charlene Hanlon, your line has been unmuted, so you can go ahead and ask your question. Charlene's still available?
Charlene's checking email
now,
I think.
Yeah, we can just go to the questions. Can you comment on any unique components of designing practice models to incentivize productivity in an academic setting?
Chris or Randy?
I cannot.
Okay.
Nor I.
All right. You guys are mostly non-academic in your
That's
practice.
correct. On my side, yes.
Well, I think it makes sense to include a productivity component in an academic setting, and I think it could certainly be RVUs, or it could be billed encounters. Now, obviously, the dollar amounts applied, the expected number of RVUs annually, all those things would need to be scaled differently for somebody in an academic setting than somebody in a non-academic place. But I think that those who are more productive, it makes sense they could be rewarded more. Now, I realize that you could make the case that it's the residents who are really going to control how busy you are, and therefore the residents own which patients get accepted to the service and which ones don't, and that then is going to be the basis of the attending's compensation. That may seem a little unfair, but I think as an attending, you have an influence over how the team works, and ultimately that influences the overall productivity. Also, if you pay on productivity as measured in RVUs, you are building in a personal financial incentive for that doctor to pay attention to CPT coding. So in an academic setting, that's certainly valuable that the attendings are concerned with and want to ensure that CPT coding, documentation of CPT coding is done well. So I think it's less critical to have a productivity component in an academic setting, but you certainly can still do it. There's nothing about it that means that it wouldn't work.
We also have a question about when the SHM salary information for academic hospitals programs will be available, and that information was released with the productivity, the State of Hospital Medicine survey that was just released yesterday. So we currently have that information for sale in the survey.
Yeah, just so hot off the press, just became public yesterday?
That's right.
The academic survey? How about that? A timely question.
So the next question that we have for the panel is, what are some of the more unusual quality metrics that you've seen or used? Or do most groups just stick with core measures and discharge-related measures?
Guys? I have some things I can say.
We put in meeting attendance, committee participation.
Yeah, completion of medical records in a timely way. Some places do that. Completing med reconciliation. There was a survey done, I think, in 2008, and the link that, I guess if you're still looking at the screen, I've left this slide about references. So the first link there goes to a summary of a 2008 survey about what metrics were currently in place. And that survey said that 24% of those practices that have metrics in place, so not 24% of all hospitalists, but of those that have some sort of performance incentive, 24% said that they were paid for avoiding unapproved abbreviations, which I thought was pretty unusual. I've never encountered a place that does that.
We have a kind of a follow-up, a related question to that. How do you distinguish between attendance and participation when using those types of metrics in your compensation incentives?
Great question. Chris or Randy, you want to say anything about that?
I think I think for us, you must be present to win. We don't get that deep.
Yeah, that's the way most places set it up. It's just, you just have to show up. But I don't know if some of you are aware, I write a monthly column in the Hospitalist about practice management, and one that will appear in a month or so is on the topic of citizenship and how to use a salary incentive to actually encourage more than just showing up and instead active participation. It turns out, in my experience, that's pretty difficult to do with a salary incentive. You can create a citizenship bonus. So, for example, it could be based on attending X% of your group's meetings over the year and completing some sort of project for the group. And the project could be creating a new order set for a diagnosis. It could be creating a progress note template that facilitates good CPT coding. It could be developing a new way the group communicates internally. So develop a wiki, for example, an online way that the group posts information. Any of those kinds of things would qualify as a reason to be paid the citizenship bonus. And I think it works. I think that does get people to be engaged and get people to sort of get off their duff and do more than just see the next patient on their list. But it has sort of some tricky effects. So it's not a simple thing to create a citizenship bonus. There is the possibility that as soon as that citizenship bonus were to go away, everyone will stop doing anything at all. You actually will be worse than you might have been before you implemented it. I think that's a risk. So how to measure and encourage active participation rather than just presence, I'm not sure anybody has fully figured that out. I guess another thing to say is do it in the way you recruit. Recruit people who just by their personality and interest will be inclined to be engaged.
Okay, our next question is, with many hospitals investigating ACO designation, the increase of bundled payments and value-based purchasing, what do we anticipate the impact will be on our provider reimbursement structure moving forward?
That's a Chris question.
You know, we don't know. You know, it's a big function of when we get together with our hospital organizations who are leading these ACOs. How much are we able to negotiate out of that pie? And it's really an individual question.
Right. Well, I think it's sort of interesting. Historically, doctors have been paid, or doctors have been connected directly to market forces in the way that their compensation has been determined. So in other words, private practice was a predominant model, and doctors got paid basically whatever they could collect minus their overhead. So their compensation was directly influenced by things in the marketplace. Now, most hospitalists aren't in that situation at all. In fact, they're more like sort of a planned economy, almost a communist kind of situation where money comes into the practice from usually from two sources, from professional fee collections and money provided by the hospital. And those two revenue streams are pooled, and then there's some formula used to determine how much of that revenue the hospitalist is paid. So I think even if physician compensation is changed dramatically, if Medicare bundles payments, or if there are big, huge changes to the way physician work is compensated by payers, that doesn't automatically mean that there will be parallel changes to the way hospitalists are paid. Now, over time, unquestionably, there will be changes. And I actually think the best compensation plan for a hospitalist is one that connects the doctor to the market reality. So I think today the market reality is largely revenue is a function of productivity. So that's a reason it makes sense to pay doctors based on productivity. Quality performance is becoming an increasingly important component of revenue, and so it makes sense that that is showing up in hospitalist salaries. So if payments are bundled in the future, then I think we need to know very clearly what results in ensuring good revenue and for the physician's efforts, and then turn around and pay the doctor their salary in a way that connects them to the revenue that's generated. So, I don't have anything specific to offer in response to that question other than a bunch of philosophical ideas.
Okay. When RAC audits include physician repayment, how could or should that affect hospitalist reimbursement?
Wow. You guys do anything at Team Health in that regard? I know you've had some RAC audits. You have to, statistically, you have to have been audited a few times.
We do not link the RAC results to individual physician compensation.
Yeah. And what I'm seeing happening, what we do where I practice is we incentivize proper documentation and coding. So we have 2 audits each year. So every hospitalist has a random chart audit twice a year, and the coder has to judge that the doctor chose the correct CPT code 90% of the time or better on each of those audits. If that happens, you get a bonus. And so that's sort of that's a way to prepare us to do well when we have RAC audits. But if an audit occurs and we pay money back, the doctor learns of it, but is not financially affected by it to this point.
Yeah, one of the beauties of the RVU compensation-based model is the RVUs, they compensate productivity, they reward you for acuity, and they reward you for proper documentation. So it's kind of built into those things. We don't have our doctors code at Team Health. We have coders do it, but we do a lot of documentation training for them to make sure they're doing it properly, and I think that really goes a long way.
Right. Yeah, it's a good point. Paying on RVUs, you all are already incentivizing the doctor to pay attention to the documentation and coding. And we do that, plus have an actual incentive around doing well on the audits.
Okay, we have time for one final question, so we're going to go ahead with what are doctors asking for in terms of compensation incentives when you are contracting with them?
What do the doctors ask for?
Yes, in their negotiations.
The hospitalists in my experience, aren't as a rule sort of clamoring and making a racket about having a performance incentive. I think the general sentiment of practicing hospitalists, most of them still are most comfortable with principally fixed compensation, and they're not going to be the ones to bring up changing that. But if you tell them, look, we're going to have a performance incentive, they tend to talk about that their preference would be to do it around things like core measures as a rule. But I think the general sentiment of the hospitalists is, you know, we're not waking up every day thinking about implementing a new incentive in our program. Team Health have any different experience?
I think it's pretty consistent with what I'm seeing as well.
Okay.
Do our panelists have anything final they'd like to add before we conclude today's session?
I'm happy to hear from anybody. If you have questions or want to discuss these things further, my phone and email are on the first slide if you go to download the presentation. And Meredith, you said in your scripted comments that it'd be about a week. Is it often much sooner than that the presentation is available for download?
Yeah, it should be within the week.
And how do they go to find? Where do they go to find it?
You're going to go to the Practice Management Institute Online Resource Center, and it'll be on the right-hand side. There's a tab that says Roundtable Series. So the Practice Management section of the website, tab that says Roundtable Series, and the presentation will be available. Okay.
You can also do a Google search on my name to get my email address. Email me. I'll send it to you also. So either one.
Okay. Well, thank you very much. Go ahead. Thank you very much for those who participated. If there was a question that was not answered that you would like to be asked, please email John, or you can email Meredith Myers, Myers, M-Y-E-R-S, @hospitalmedicine.org, and we will send the question along to John. Thanks so much, everyone.